the problem of ataxia, how to approach to this problem will be justifiably dealt with by no more than an austere clinician by Dr. Biman Kanti Rai. With these few words of introduction, I now hand over to Dr. Rai for his further proceedings with the subject. Dr. Biman Kanti Rai, please.
মিনালদা স্লাইড গুলো দেখা যাচ্ছে? স্লাইড শেয়ার করেছি, দেখা যাচ্ছে?
ফুল স্ক্রিন করো, ফুল স্ক্রিনই
করা আছে,
হচ্ছে না।
স্লাইড চেঞ্জ হচ্ছে, বোঝা যাচ্ছে
না? বিমান, তোমার স্লাইড চেঞ্জ হচ্ছে না, ফুল স্ক্রিন হচ্ছে না।
ফুল স্ক্রিন হচ্ছে না, ফুল স্ক্রিনও নেই,
ফুল স্ক্রিন করা নেই বিমান, ফুল স্ক্রিন করা নেই।
আচ্ছা, আবার একবার দেখছি।
হ্যাঁ, এবারে ঠিক আছে।
এখন দেখা যাচ্ছে?
Yes, it is okay now.
Fine.
এখন ফুল স্ক্রিন আছে।
আচ্ছা, চেঞ্জ হচ্ছে, এটা বোঝা যাচ্ছে?
হ্যাঁ, ঠিক আছে, চলে যাও।
ঠিক আছে, আচ্ছা,
you can proceed.
Good morning, everybody. First of all, I convey my sincerest thanks and regards to all my seniors who has given me this opportunity to share this presentation with all of you. Today my topic is approach to ataxia. I always believe as a clinician, when you approach any problem, at the very beginning you must have a very clear understanding about the neuroanatomy related to that particular problem. When you talk of ataxia, mostly it is equated with a problem of the cerebellum. We all know cerebellum, as it is popularly called little brain. By weight, it is 1/6 of the whole brain, but it contains almost about 80% of all neurons in the brain. And cerebellum is the main structure which is responsible for maintenance of our coordination. But you must always appreciate that it is not only the cerebellum which is to be blamed for any ataxia. All the input to the cerebellum that is done by the proprioceptive system or the dorsal column, if there is any pathology in that part, that can also lead to ataxia. So at the beginning, I will give a brief overview of the neuroanatomy related to ataxia, and in the next part, I will give a brief outline about the step-by-step approach to ataxia. As you all know, anatomically, cerebellum has 3 different lobes. One is anterior lobe, next is posterior lobe, and in the inferior part there is flocculonodular lobe. The anterior lobe is separated from the posterior lobe by the primary fissure in the superior surface, and in the inferior surface of the cerebellum, the posterior lobe is separated from the flocculonodular lobe by posterolateral fissure. So there are 3 lobes: anterior lobe, posterior lobe, and flocculonodular lobe. This is the anatomic division. When you talk of functional classification, cerebellum is divided into 3 parts: vestibulocerebellum, spinocerebellum, and cerebrocerebellum. That is the cerebellar hemisphere. Phylogenetically, this vestibulocerebellum is the oldest part of the cerebellum. It is also called archicerebellum. And if you relate this functional division, vestibulocerebellum, to anatomic division, it corresponds to flocculonodular lobe. So flocculonodular lobe is equivalent to vestibulocerebellum, is equivalent to archicerebellum. Phylogenetically, the next order is paliocerebellum, that is spinocerebellum functionally, And if you talk of anatomic division, it mostly is in the part of the vermis. And the third part, that is cerebellocerebellum, that is the cerebellar hemisphere, that is functionally, phylogenetically is neocerebellum. So these are the terminologies you commonly encounter: archicerebellum, paleocerebellum, neocerebellum. Archicerebellum equivalent to foculoneural lobe, equivalent to vestibulocerebellum. Paleocerebellum equivalent to spinocerebellum, equivalent to vermis and paravermis. Neocerebellum equivalent to cerebellocerebellum, that is cerebellar hemisphere. Next, for clinical purpose, we have to know the basic functions of these different functional divisions of the cerebellum. The vestibulocerebellum mainly controls the axial musculature through its contact with the vestibulospinal tract. And this is very important in control of pursuit eye movement and also control of eye and head movement. So remember these three things. One is control of axial musculature, control of eye movement, and control of coordination of head and eye movement. This part is done by the vestibulocerebellum, that is the foculoneural lobe, that is the archicerebellum. If you talk of spinocerebellum, whenever we do any action, if this action has to be smooth and accurate, there are two components. One is what is the intention of the primary motor cortex. That is the intended motor commands of the primary motor cortex. And what is the actual somatosensory feedback received through different inputs. So these are the two important components. One is motor commands by primary cortex, and other is somatosensory feedback received through different inputs. So what spinocerebellum does, it continuously compares between these two, and ultimately it adjusts the motor outputs to correct for any deviation in intended motor movement. So this is the function of spinocerebellum, that is the vermis and paravermis, and phylogenetically that is paleocerebellum. And the function of cerebellar hemisphere, that is neocerebellum, is to control the ipsilateral sides of the body. So by this time we have known the different parts of cerebellum and different functions related to the different parts of cerebellum. So the key point is vestibulocerebellum is concerned with equilibrium and eye movement. Spinocerebellum controls the axial and proximal limb muscles, particularly the vermis part, whereas the paravermal regions control the distal limb muscle, and cerebellar hemisphere controls the planning and programming of any movement. I have already told not only the cerebellum, the other important component to maintain our balance is the sensory system. And in the sensory system, the most important part is proprioception. That is the sensation of joints and position sense. In the peripheral nervous system, the important anatomical components which convey this information are receptor, afferent nerve fibers, dorsal root ganglion, and dorsal root. If you continue this track upwards in the central nervous system, this is the ascending tract in the spinal cord and brainstem. Then it reaches the thalamus. Then ultimately it reaches the somatosensory area in the cerebral cortex. So if there is any pathology in any of these components of the sensory system, there will be ataxia. If you look at this picture, this is the receptor, this is the proprioceptive receptor, then there is afferent nerve fiber, then it goes through dorsal root ganglion, then ultimately ascends upwards ipsilaterally, then it reaches the brainstem. Up to this is the first order neuron. Then at this level, there is decussation to the contralateral side. There is formation of medial lemniscus, and ultimately it reaches the thalamus. And from thalamus, the thalamocortical projection goes to the primary somatosensory cortex. So whenever you suspect ataxia due to some sensory system disorder, the pathology must be anywhere in this pathway. Again, I am telling, it may be in the receptor, in the afferent nerve, in the dorsal root ganglion, in the dorsal column of the spinal cord, in the medial lemniscus of the brainstem, or it is in the thalamus, or it is in the primary somatosensory cortex. With this brief understanding of neuroanatomy, we proceed to the next step, that is the step-by-step approach to a clinical problem of ataxia. So let us start with the case history. So it is a case of a 56-year-old male patient, smoker, non-hypertensive, non-diabetic. He presented with imbalance, progressive gait difficulty, difficulty in walking upstairs and downstairs for last 2 years, frequent fall for last 1.5 years, bad handwriting for last 1 year, slurred speech for 1 year. There are 2 episodes of syncope, and there is history of urinary urgency and urge incontinence. With this history, he presented to our OPD. On examination, he had bilateral gauge-evoked nystagmus, first component towards the direction of the gauge. He had slow saccades, broken pursuit. There was truncal sway. There was finger nose ataxia and dysdiacokinesia. There was extreme difficulty to perform tandem walking. He had slurred speech, orthostatic hypotension, mild rigidity, and hypomimic facial expression. So that was the case history and that was the examination finding. Now, whenever you, I think all of you in your clinical practice or in your post-graduation days, you have come across this type of presentation. So if you look at the history part very carefully, the most important symptom which the patient presented to us is imbalance of gait. And there are some other symptoms as well. But that was the most important part in the history, and it started around 2 years back in a 56-year-old male patient, and the symptoms were gradually progressing. So in the first step, you have to clarify what exactly means by ataxia. In this particular patient, he has presented with imbalance while walking. But you must remember, sometimes patient may not give this type of clear-cut history. They may use different words to express their difficulty. Sometimes they tell, doctor, I am having vertigo, I am having imbalance, I am having lightheadedness, and some people tell, I am having near faintness. So these are the different words they use while describing their difficulty. Regarding vertigo, one part is very important. You always inquire whether there is a sense of rotation, be it rotation of the patient's head or be it rotation of the surrounding. It may be either. But always inquire this history, whether there is any sense of rotation. Now, if you are really dealing with a case of ataxia, you always ask some other questions to establish that it is really ataxia. So, as in this case, the patient has told he has difficulty in going upstairs or downstairs. Sometimes they tell they have to hold on to the railing, otherwise they cannot walk. some patients may tell they have trouble walking in narrow lane or veering to one side. They may have history of frequent fall. And it is very useful if you ask specifically, do you feel you are walking like a drunk? So these types of questions can tell you whether the patient really has the symptom of ataxia. Once you are confident that the presenting problem is ataxia, in the next step, you always think in your mind, what is the probable anatomical substrate? At the very beginning, I told it may be in the either cerebellum or it is in the sensory system. So you ask yourself, is it a primarily cerebellar disorder or combination of both, or is it a primarily peripheral vestibular disorder? Here I must clarify, whenever we use the term vestibular ataxia, we mean it is peripheral vestibular ataxia. You all know the vestibular system has a central component and a peripheral component. The peripheral component starts from utricle and saccule of the inner ear, and it ends at the level of vestibular nucleus in the lower brainstem. So the peripheral vestibular part contains vestibular nerve and utricle and saccule in the inner ear. The central vestibular pathway, which starts from vestibular nucleus and ascends upwards, that is a part of cerebellar connection. So, if we tell this patient has vestibular ataxia, it is implied that this ataxia is peripheral vestibular pathology, not central vestibular pathology. Central vestibular pathology is almost synonymous with pathology in the cerebellar connection. So at the very beginning, you ask this question, cerebellar, sensory, combination of cerebellar sensory, or it is primary peripheral vestibular. But before you establish the anatomical substance in any of these four categories, you always rule out whether there is any musculoskeletal problem. If they have some musculoskeletal problem, they may present like ataxia. Whether the patient has any history of weakness, upper motor or lower motor. Sometimes weakness may present like ataxia. Whether the patient has any extrapyramidal involvement, basal ganglia disorder. Sometimes a Parkinsonism patient with Parkinsonism may present like ataxia, or whether this is a frontal ataxia. So these are the four things you exclude at the very beginning: musculoskeletal, muscle weakness, LMN or UMN, basal ganglia disorder, or frontal ataxia. Now, there are some clinical clues. If it is a cerebellar ataxia, this I always tell to my students, you start from above, go downwards. If it is a cerebellar ataxia, the important clinical clues are the patient may have problem in the eye. There may be eye symptom. Particular symptom is blurring of vision when they are turning, or there may be eye sign. The patient may have head titubation, truncal ataxia, stance ataxia, gait ataxia, limb ataxia. So all types of ataxia, truncal, stance, gait, limb ataxia may be present in different combination in cerebellar ataxia, in addition to eye symptom, eye sign, and slurring of speech. So constellation of these symptoms and signs in different combination will give you a clue that the patient may have a cerebellar pathology. If we come to the part of sensory ataxia, the three important points you have to remember. One is presence of sensory symptom like paresthesia or numbness. And there may be history of disproportionate aggravation of symptom in darkness. And contrary to cerebellar ataxia, patients with sensory ataxia will have normal speech. So normal speech, positive sensory symptom, and aggravation during darkness, these are the important pointers for sensory ataxia. And the most important part in vestibular ataxia is the presence of prominent vertigo. Speech is relatively spared. During examination, I have already mentioned these points. In cerebellar ataxia, you get positive finger nose test, rebound phenomenon, dysdagokinesia, impaired tandem walking, hypotonia, in addition to oculomotor abnormalities and scanning speech. In sensory ataxia, you get loss of deep tendon reflex, absence of joint position and vibration sense, no oculomotor disturbance, and high steepage gait. And if it is a vestibular ataxia, the head impulse test is positive and there is characteristic peripheral vestibular nystagmus. This is for my postgraduate students. If you cannot always remember what should be the characteristics of peripheral vestibular nystagmus, you always remember the findings of calorie test. In peripheral vestibulopathy, there is less vestibular tone on one side. Suppose a patient has right peripheral vestibulopathy. In that case, the right vestibular tone will be diminished. So the left side will take the upper hand. So eye will be deviated towards the right side. In that case, there will be a corrective nystagmus to the opposite side. So in case of peripheral vestibulopathy, there will be always unilateral nystagmus, and that is opposite to the side of lesion. By that way, you remember how to differentiate between peripheral vestibulopathy nystagmus and cerebellar nystagmus. Cerebellar nystagmus is always a bidirectional nystagmus, whereas peripheral vestibulopathy is unidirectional nystagmus, and the first component is on the side away from the lesion. Now, if you suspect that a patient has sensory ataxia, then you further scan the findings and the history. Because in sensory ataxia, as I have already mentioned, the problem may be in the peripheral nerve. Obviously, the large fiber peripheral nerve, because these are carrying the proprioception. Or it is a problem of the dorsal root ganglia. Or it is a problem in the dorsal column in the spinal cord. Or medial lemniscus in the brainstem, or parietal lobe. Now, always first have a clear idea how to differentiate sensory ataxia due to different anatomical substrate involvement in the sensory system. This you can do only depending on two features. One is distribution of symptom and the presence of associated symptom. In case of peripheral neuropathy sensory ataxia, the distribution of symptom is in the glove and stocking distribution, distal symmetrical, glove and stocking distribution, and it is always length dependent. Whereas if it is a dorsal root ganglion, the distribution is non-length dependent. That is, it will involve the proximal part of the limb or even the trunk at the early part of presentation. Contrary to peripheral nerve, where the symptoms and signs always start distally and then proceed proximally in a glove and stocking distribution. So one is length dependent, that is peripheral nerve sensory ataxia, and one is non-length dependent, that is dorsal root ganglion sensory ataxia. If it is a problem in the dorsal column in the spinal cord, in that case, the distribution will always be below a particular level. So you get findings below a particular level that tells you the pathology is in the spinal cord, dorsal column. And always also try to elicit associated symptom. If it is a peripheral neuropathy sensory ataxia, there will be element signs, loss of reflexes, and since peripheral nerve also contain motor fibers, there may be muscle weakness, muscle wasting. So combination of sensory symptom and motor symptom and element finding tells you it is a problem in the peripheral nerve. In the dorsal root ganglion, again, the reflexes may be lost, but the important point is there will be sensory motor dissociation because dorsal root ganglion contains only sensory fiber. So if a patient has severe ataxia, non-length dependent ataxia, sensory symptoms in the distribution of trunk, proximal and distal limb, and there is no motor finding, you always think it may be in the dorsal root ganglion because here there is clear-cut sensory motor dissociation because the motor fibers are going through anterior root. So if there is any dorsal root ganglion pathology in ganglionopathy, there will be no motor weakness. Severe ataxia, no motor weakness, non-length dependent distribution, think of ganglionopathy. In case of dorsal column involvement, you may get sign of myelopathy in addition to sensory symptoms below a particular level. In medial lemniscus involvement in the brainstem, you will get brainstem sign, that is involvement of multiple cranial nerve palsy or Horner syndrome. And if the ataxia is due to parietal lobe involvement, you get symptoms like seizure, headache, and there may be impairment of cortical sensation. So by that way, from history, examination, and particularly focusing on distribution of symptom and associated symptom, you try to differentiate which part of sensory system is involved in sensory ataxia. So by this time, I hope I have made it clear how you suspect sensory ataxia from symptom, from sign, and how you establish which part of the sensory system is involved. Once you establish that, your next idea will be to establish the cause of sensory ataxia. In that case, some important causes I have mentioned. One is paraneoplastic, Sjogren, vitamin B6 deficiency or B6 toxicity, Miller-Fisher syndrome. And another point I have not mentioned in the slide, one is platinum-based chemotherapy. They can cause sensory ataxia. And also B12 deficiency may cause sensory ataxia. So these are the important causes of sensory ataxia. This is not that common, but you also must know how frontal ataxia is present. In frontal ataxia, there is no limb or eye movement signs. There is no nystagmus, no heel sync incoordination, and upper limb coordination is usually normal. The most distinguishing feature in frontal ataxia is out of proportion gait abnormality. Patient may feel as if the feet is stuck to the ground or glued to the ground. That is called magnetic gait. Banglaয় বলে আটার মতো পাটা মাটিতে লেগে আছে. And additionally, you can get increased tone and exaggerated deep tendon reflex. So disproportionate gait abnormality, magnetic gait, and exaggerated deep tendon reflex and hypertonia with normal limb and eye movement tells you probably this may be a case of frontal ataxia. Now let's go back to the original case which I have mentioned at the beginning. In this particular patient had ataxia because all the symptoms of ataxia that I mentioned are present. Patient had frequent falls. Now, these frequent falls may occur due to ataxia itself. It may be due to loss of postural reflex, or it may be due to orthostatic hypotension also. So he has frequent falls. This may be a symptom of ataxia. He has bad handwriting. So that tells you that his hand movements are clumsy. There is difficulty in performing finer tasks with his hands. So there is upper lip ataxia. He has slurred speech. So if you consider this part of the history, the patient has ataxia, patient has incoordination of the upper limb, patient has slurred speech. So from the history alone, you can tell this is not a case of sensory ataxia. This is not a case of vestibular ataxia. This is a definite case of cerebellar ataxia. And what you suspect in history, that is also corroborated in the examination part. There are eye signs. He has bilateral gaze evoked nystagmus. He has slow saccades and broken pursuit, occurs in cerebellar lesion. He has truncal sway, finger nose ataxia, dysdiacokinesia, impaired tandem, slurred speech. All these points in the history suggest that our patient has clear-cut cerebellar pathology. So in this case, as I have mentioned, this patient has cerebellar ataxia. Now, once you establish a patient has cerebellar ataxia, you go to the third step. Is it a problem in the cerebellum, or is it a problem in the connections of the cerebellum in the brainstem, where the same problems may occur? In the history and examination, if you get only cerebellar signs and symptoms, no brainstem sign, the problem is only in the cerebellum. If you get, in addition to cerebellar features, pyramidal tract signs, cranial nerve palsy, or Horner syndrome, then the problem is in the connections in the brainstem, connections of cerebellum in the brainstem. So once you get ataxia due to pathology in the cerebellum or its connection, you try to formulate whether it is purely cerebellar or it is a brainstem or cerebellar brainstem connection. Now, in this particular patient, I have mentioned there are features other than cerebellar involvement. Now, first try to concentrate on the cerebellar part itself. Now, in the very beginning of my presentation, I told there are different parts of cerebellum. So you have already established there is cerebellar problem. Then your next question in your mind will be, which part of the cerebellum? Is it one side of the cerebellum? Is it midline cerebellum? Or it is cerebellar hemisphere? In unilateral cerebellar lesion, there will be ipsilateral symptoms and signs. Very simple. In case of midline cerebellar involvement, there will be predominant involvement of the trunk and leg. In cerebellar hemisphere lesion, there will be predominant involvement of the arms. You just remember these 2 points. Midline cerebellum, involvement of the trunk and legs. Cerebellar hemisphere, involvement of the predominant involvement of the arms. Classically, cerebellum has been divided into 3 parts. One is medial part, zone-wise, medial part, intermediate part, and lateral part. The medial part of the cerebellum, that is constituted mainly by the vermis and to some extent flocculonodular lobe. If there is involvement in the medial part of the cerebellum, the most important findings are oculomotor disturbance, including nystagmus and gait ataxia. So eye sign symptom and gait ataxia, you get this combination. it is a problem in the medial part of the cerebellum, that is vermis and flocculonodular lobe. Classical example is medulloblastoma. If there is involvement of the intermediate part of the cerebellum, that is paravermis, that is spinocerebellum, there will be involved. There is important findings are gait and stance ataxia and dysarthria, and the classical example is alcoholic degeneration. And if there is involvement of the lateral part of the cerebellum, there will be limb ataxia, and examples are stroke or neoplastic lesion. If all parts of the cerebellum is involved, the important causes are paraneoplastic, degenerative, or viral cerebellitis. Now, let's go back to the original history again, just for recapitulation. This particular patient had gait ataxia, so he had midline cerebellum involvement. He had bad handwriting, so there is involvement of the arms, so there is involvement of the cerebellar hemisphere. There is slurring of speech, that suggests there is involvement of the hemisphere or paravermal region. So this particular patient has pan-cerebellar involvement, and the history is for last 2 years. So from the history and examination, now we can conclude that this 56-year-old gentleman has chronic progressive pan-cerebellopathy. So that should be your bedside diagnosis from the history and clinical examination. So up to this part, we have already very clear that he has cerebellopathy, it is pan-cerebellopathy, it is chronic pan-cerebellopathy, and it is a case of chronic progressive pan-cerebellopathy. But you must not restrict yourself only to cerebellum and sensory system and vestibular system. You always look beyond cerebellum. So whenever you get such cases, don't forget to examine from above below. You always try to find out whether the patient has any problem of cognition, any supranuclear gauge weakness, any pyramidal, extrapyramidal involvement, any autonomic neuropathy, peripheral neuropathy, myoclonus. So make a very clear idea that whenever you get any predominant cerebellopathy, you don't forget to look beyond cerebellum. Again, go back to this history. This particular patient had 2 episodes of syncope, and there was urinary urgency and urge incontinence. That tells you probably this patient also has dysautonomia. This patient also has mild rigidity and hypomimic facial expression. That tells you probably this patient has extrapyramidal system involvement. And the slow saccades which he had may be a feature of supranuclear gauge involvement. So from the history and examination, you can tell this patient has chronic progressive pan-cerebellopathy with dysautonomia, with extrapyramidal involvement, with probable involvement of supranuclear gauge. So once you get all this information from the history, your etiological diagnosis become very obvious. So once you get all the findings, next plan, that is step 4, is to establish the etiology of a particular case. As in any case, the most important part to establish the etiology is the pattern of onset, distribution of symptom, and the course of the symptom. It may be acute, subacute, chronic onset ataxia. Distribution, as I have already mentioned, it may be in different parts, and the course may be acute, subacute, chronic, or episodic. If a patient, I am now going to another part of the discussion, not this particular case. if a patient presents with acute onset ataxia, which develop within hours to few days. So as in any etiology, two important etiology you must always keep in mind. One is vascular. So is it a manifestation of a stroke or is it a demyelination? If it is a demyelination, it can be a primary demyelination like multiple sclerosis, like NMO spectrum disorder, like MOC antibody disease, or it can be a secondary demyelination due to some post-infectious syndrome or any underlying collagen vascular disease. And the other important causes of acute onset ataxia are infection, particularly viral, and toxic or metabolic causes. Most important is alcohol. One is encephalopathy, and the other I have not mentioned in this slide is heavy metal poisoning, particularly lithium, lead poisoning. So in acute onset ataxia, these four groups you always keep in mind: vascular, demyelination, infection, and toxic. If it is a subacute onset, progressive, then the important groups are, one is immune mediated disorder. Whenever we get any subacute onset progressive ataxia due to cerebellopathy, the important immune disorder we try to exclude in our ward is paraneoplastic pathology, anti-gliadin antibody, anti-GAD antibody, anti-TPO. These are the four things: paraneoplastic, anti-TPO, anti-GAD, anti-gliadin. And the other important causes are infection, particularly CJD and HIV. If a patient presents with subacute progressive ataxia, don't forget to examine for any evidence of dementia or any focal myoclonus. So always look for myoclonus. Always look for any cognitive impairment if a patient has subacute progressive ataxia. And if the clinical situation fits, always rule out the possibility of HIV disorder. And if the ataxia is chronic, develops over months to years, the differentials become very narrow. If you consider a relatively young onset ataxia, chronic progressive course, obviously the possibilities are genetic ataxia or mitochondrial disease. If it is a late onset chronic progressive ataxia, now in our clinical practice we frequently get this type of patients who are presenting with chronic progressive ataxia late onset. The possibilities that we always consider, one is degenerative, particularly multiple system atrophy. Next, it may be a case of paraneoplastic cerebellopathy. Third, it may be ataxia due to gluten sensitivity. And rarely, it can be idiopathic late onset cerebellar ataxia. So these are the four important chronic ataxia at older age: MSA, paraneoplastic, gluten sensitivity ataxia, and idiopathic late onset cerebellar ataxia. And if it starts at younger age, the most important possibility is genetic ataxia and mitochondrial disease. Now, if we go back to our own case that I presented at the very beginning, this patient is 56 years old. Course is progressive, chronic. So chronic, progressive, late onset ataxia with prominent autonomic dysfunction with extrapyramidal involvement. So among all these possibilities, the first possibility that should come to a differential diagnosis is multiple system atrophy. There are, this is another group we should remember. There are episodic ataxia, and the important causes are some genetic episodic ataxia due to channelopathy, psychogenic ataxia, some mitochondrial disease may also present with episodic ataxia, and multiple sclerosis, as you all know, it presents multiple times at multiple sites, and they may present with episodic cerebellar ataxia. And the last part of my presentation, just few minutes, this is only for my students. In adult practice, you don't see this type of cases very commonly, but in neurology practice, we do see this type of cases. And the genetic ataxia, whenever you get any genetic ataxia, as I've already mentioned, it is usually age of onset is younger age of onset, and it may be autosomal dominant ataxia, that is spinocerebellar ataxia. They present usually in the second decade of life. There are multiple types of scar, now up to 48 types of scar described. It may be autosomal recessive ataxia, it may be X-linked, or it can be mitochondrial, like MELAS or MAR. I'm not going details into it, but if it is a autosomal, in case of autosomal dominant ataxia, that is SCA, you can identify it at bedside from their age of presentation and the associated feature. They may be associated with peripheral neuropathy, extrapyramidal development, eye movement problem, like that. And different genetic disorder have different phenotypic presentation. In autosomal recessive ataxias, their age of presentation is earlier, first decade of life or second decade of life. And for clinical purpose, broadly, this has been divided into three groups. One is cerebellar ataxia with predominant sensory neuronopathy. The classical example is Friedreich's ataxia, where there is ataxia with features of neuropathy. And another less commonly seen is SANDO, that is sensory ataxic neuropathy, dysarthria, and ophthalmoparesis. The second group is cerebellar ataxia with sensory motor axonal neuropathy. In the first part, it was only sensory neuropathy. In the second part, it is cerebellar ataxia with sensory motor axonal neuropathy. The classical example is ataxia telangiectasia, ataxia with oculomotor apraxia, and CTX, that is cerebrotendinous xanthomatosis. Third group is cerebellar ataxia without any sensory neuropathy, that is Niemann's peak, where there is ophthalmoplegia, vertical gaze deficit, splenomegaly, and cherry red spot. So, if you suspect genetic ataxia due to autosomal recessive disorder from their age of presentation, it can be either in any of these three groups. One is ataxia with sensory neuropathy, ataxia with sensory motor axonal neuropathy, ataxia without neuropathy. And in different groups, there are different examples. I'm skipping this slide. So the final take-home message is you have to have some understanding of the neuroanatomy of balance. Then first you always rule out any musculoskeletal problem or muscle weakness. Focus your history to pinpoint the specific anatomical substrate or substrates. Corroborate your symptoms during examination. Always look beyond cerebellum or peripheral nerve. And finally, you properly interpret the onset, tempo, and the associated symptom. That will give you clue to the exact diagnosis. Thank you, sir.
Thank you, Dr. Rai, Dr. Biman Rai. Am I audible, Biman?
Audible.
So you have done excellent job. You have done an